Trust in a series of webinars that we've done as part of a quality improvement project. So we've got a talk from Dr. Rebecca Dawber, who is a palliative care consultant here at Sandwell and West Birmingham NHS Trust, and she's going to update on the progress and the future direction of the quality improvement project that we've been doing. And then we've got Dr. Mike Blaber, who is a palliative care specialist and wellbeing lead here at the Trust, and he is going to talk about navigating uncertainty at the end of life in palliative care. Just a couple of housekeeping things. Can you please turn off videos and mute yourselves during the talks? With questions, you can either pop them in the chat and we'll monitor the chat, or we'll have a time after each talk for questions. Just raise your hand or just unmute yourself and talk. There's only a small number today, I think, so you feel free to shout out, but try and keep it to the end of the talk if possible. I think that's it, really. So I'm going to hand over to Becky, who's going to start the talks. Thank you.
Hi, everyone. Thanks for coming. So just over a year ago now, we embarked upon a community quality improvement project for palliative and end-of-life care. And we did a webinar at the time really to talk about it and what we were intending to do. So as we're over a year on now, we thought it would be good to give you an update on what we've been doing, what progress has been made. So that's what I'm going to do. So I'm presenting it, but very much this is not only my work. Carolyn has been leading on this work with me, and there's been lots of other people within our team kind of involved as well. So could you move the slide on, please, Carolyn? So just to recap, the kind of driver for how we aim to provide palliative care for patients, the kind of policy document is the ambitions for palliative and end-of-life care, which was initially written in 2015, expired in 2020, but actually was then extended to 2026. So we've had the same kind of policy driver for a long time. And the vision set out in that document is that I can make the last stage of my life as good as possible because everyone works together confidently, honestly, and consistently to help me and the people who are important to me, including my carers. And the way that they suggest to do that is by 6 steps or 6 ambitions. So each person is seen as an individual, each person gets fair access to care, maximising comfort and well-being, that care is coordinated, that all staff are prepared to care, and that each community is prepared to help. Can you move on? Thank you. And that ambitions document really informs our local strategy. So there's a palliative and end-of-life care strategy for the Black Country, and it reflects those ambitions. And we used that strategy when we developed this QI, and we came up with 3 work streams. The first one's community engagement and bereavement. The second was education, and the third was primary care. And it's the primary care work stream that Carolyn and I have been leading on. And the aim of the primary care work stream was to support community services and general practice to provide better, more proactive care in the last year of life. And the thing that we tried to focus on was identification of people in the last year of life, because we knew at the time of starting this project that across Sandwell, we are particularly not good at that. And until you identify that people are in the last year of life, it's hard to do anything else about improving their care. Next slide, please. So just a little reminder of kind of the national picture. 66% of the British population say they'd like to die at home. And locally, our figure is 27.7% in Sandwell. Nationally, it's 50%, so we're not as good as the national picture. We know that as people get nearer to death, they access urgent care more. And on average, dying patients spend more than 6 of their last 52 weeks in an acute hospital bed, and that's very much loaded towards the end of their life. We also know that 80 to 90% of deaths are expected, so they can be predicted. And at any one time, 1% of the population is in the last year of life. So therefore, every GP practice, we can say that roughly 1% of each practice list is in the last year of life. Now, we talked a lot about this figure when we devised this project. If 80 to 90% of deaths are predictable and 1% is in the last year of life, it would be unrealistic to expect that 1% of your list would be identified. So maybe we said maybe 0.7 to 0.8% would be the best that we can aim for, really. So at the start of the project, so this is data from December 2022, in Sandwell, we were only identifying 0.12% as in the last year of life. The way we got that statistic was from how many people were on an end-of-life register. Wolverhampton were equally as bad. Walsall were a bit better, and Dudley are doing quite well. So we came up with a bit of a strategy for how to try and improve this. So we've basically been reaching out to GP practices one by one, trying to identify who's the palliative care lead, and finding people to go and meet with and talk through what's happening currently in the practice in terms of identification of patients, what's being done in the way of advanced care planning for those patients, how the MDTs are being run. Do you even have an MDT? Just finding out what the lie of the land is in each practice and what areas need support or help, and how we might be able to provide that support. We've been to just under half of practices in the locality so far, so we certainly haven't been out to everybody. We've met with GPs, but we've also met with practice managers and AHPs, so we've had a kind of very multidisciplinary engagement. We've taken out resources that we developed, which give advice on kind of the structure for MDT meetings, but also tips for how to identify people who might be in the last year of life. We've offered bespoke support to certain practices, so we haven't had a kind of one-size-fits-all approach when we've been out to meet people, because the situation is very different practice to practice in terms of what would help. So Carolyn's been out and offered support to a few practices aside from the initial meetings. While we've been out and met people, we have identified that there's quite an appetite for education, but that in GP land at the moment, actually having protected time for education, I know is difficult, and some of the educational time's been taken away. So that's why we came up with the idea of this webinar series, so a remote kind of channel for education over a lunchtime period. But we've also recorded all of the webinars, and they're on our Connected Palliative Care YouTube channel so that they can be accessed at any time, because we know it's not always easy to be in a certain place at a specific time, depending on clinics and home visits and all of the other things that you're trying to juggle. And I'll show you in a minute how to access those. While we were going out meeting GPs and colleagues, we did hear a lot of kind of frustrations with palliative care and processes, and it seemed like there were things that we could be doing better to provide that coordinated care in a more seamless way. So we held a GP engagement event where we openly asked any GPs in the locality to come and speak with us, and we had two GPs come along, and we talked through some of the frustrations that we'd heard as we were going along. So has all of the things that we've been doing made any difference? So yes, I think is the answer. So just to remind you, 0.12% were on a last year of life register, and now it's 0.43, and it has steadily increased throughout the period of the project, really. But Carolyn and I don't take credit for this really, because all we've been going out and doing is meeting you, talking about it, maybe bringing it to the forefront of people's minds, offering a little bit of support. But this is work that's been done within practices. So thank you to everyone who's been working hard. We only get data quarterly, so we will continue to monitor it. But for now, it seems like we're doing better. Next slide, please. Identification alone is not what we're aiming for, so that's kind of the first step, but actually there are further steps that need to happen for patients, and it's harder for us to monitor the impact of that. But what we hope is that by identifying people that they might get referred into palliative care and be allowed our support. So anyone in the last year of life can be referred into palliative care and gets 24-hour medical support, nursing support as required. Improved care and quality of life for patients through anticipated care and advanced care planning, knowing people's wishes and therefore a better end of life that's in keeping with those wishes. Reduced unnecessary workload for practices, because if you have someone who's got palliative care needs and they're known to us, we hope that largely we reduce the workload for those patients because we take on some of that. But also, you know, it should be that if you've got someone who's identified and is expecting that they might deteriorate, that you avoid those kind of Friday afternoon 4 o'clock phone calls, someone's deteriorated, what should we do? And in reduced emergency calls because care's planned. We are monitoring other things. So we're monitoring kind of how many referrals we get in from primary care, but it's actually hard to work out from that data if we've kind of made a difference to that. We can see that for the practices that we visit, there tends to be a bit of a flurry of referrals after the visit, but kind of longer term, it's hard to tell. The webinars have been quite poorly attended, but I think that's a reflection of how difficult it is for people to get away from work at that specific time to attend. But the people that have come have given positive feedback. And personally, I found it really useful to go out and meet GPs and meet all the other professionals that we've met with and kind of put a face to a name. So I see lots of people in the community and then I'm emailing or ringing GPs, but, you know, just being able to put a face to a name is really helpful, and to understand a bit what's going on from practice to practice. Some practices are really struggling at the moment, and if we're trying to get action from GP practices, it's useful to know kind of a bit more what's going on locally. So this is what our Connected Palliative Care YouTube channel looks like. If you go on Google and put in Connected Palliative Care YouTube, it's the top hit. And this has all of the webinars that we've done on there. So there's one on liver failure and palliative care, heart failure, dementia, and identification. So there's a bit of a symptom control focus and also a bit about kind of identifying last year of life for all of them. There's also some of our acute resources on there that we've made for the hospital. So there's lots of stuff on there. So we thought it'd be helpful, Carolyn and I, to just share some of the outcomes from the engagement event we did with the two GPs that came to speak with us. When we were going around, we identified 3 themes in terms of the concerns or frustrations with how as palliative care we work. One was communication, one was prescribing, and one was MDT meetings. So some of the feedback we were having was that as GPs, you feel that sometimes you're asked for medications or asked for visits and things without really not much information about why we're asking for it, what's actually happening with the patient. Sometimes you feel a bit out of the loop with what's actually happening with a patient. That you prefer email communication, but actually often a generic email is best because obviously individuals work different days and different hours, and so it has to be a generic email, but that they're not always manned 24 hours a day. So urgent requests need a follow-up call. And there was also a concern that we were telling patients and relatives that they needed a GP visit, and that either wasn't the doctor wasn't able to kind of meet the demand in the time frame, or that they felt that a GP visit wasn't needed. So we talked a little bit about that. So what we did was we updated our email database to make sure that we had the correct email for conveying requests for medications, for example. We created some new email templates that include not only what medication you're asking for or what the request is, but also a little bit of history as to why we're requesting that. So I hope that you're receiving a slightly different communication from us now. We're making sure that if we make any urgent request for medication, that we follow it up with a telephone call. And we did a lunch and learn session. Oh, I say we, I didn't do this, but someone, one of the nursing leads did with our team. Did you do it, Carolyn? No, one of the nursing leads did with our nurses. Just a bit of a learning session around requests for GP visits, how we talk about them. So rather than saying, we'll ask your GP to come and see you, we're going to liaise with your GP about what the next steps are, because I know that sometimes we might think it needs a visit and actually a telephone call would be adequate, those kind of things, and that's for you to decide. And also what we do within our team, if we're coming up to a bank holiday or a big holiday, we have out of hours pharmacy lists for who's kind of open. So we're now sharing those with general practice as well. So that's just a little thing that can help. We did have a few things that would help us as well on this front. So obviously, if we're using generic emails, if you were to change that email, it would be really useful if you updated us of that. Also, some practices are in the process of creating bypass numbers, either for patients or staff. If you create a number like that, please, if you could let us know, that would really help us. And also, if you have a generic email, because obviously between practices, they're manned at different times and different response times can be expected by our team, depending on, it's just different practice to practice, isn't it? If you could put an automated message on your generic email so that we know what to expect, and like this email is manned from 9 to 5, Monday to Friday, whatever it is, then we know if we get that email back that we need to follow that up in another way if it's urgent. At any point, if you have a complex patient or you need urgent advice, we would like you to call the hub, or if you feel like you don't know what's going on with a patient, or when we're doing something that you're not sure about, we welcome any calls to discuss patients. And it might be that you need to speak to a CNS, you can speak to a consultant if it's needed, we're all available to support. The other issue we sometimes have is that if we request scripts urgently for patients, what tends to happen is they electronically get sent to whatever is the regular pharmacy that you use as a practice. And that can sometimes cause an issue because the script has to stay with that pharmacy, but the pharmacy doesn't have that drug. And then we have to kind of get back in touch with you to ask for another prescription to go to a different pharmacy. So what we would really help us and help the patients from not experiencing a delay is if you could make sure that the drug that you're prescribing actually is in stock at the pharmacy if it's urgent. Because what we can do, if you find that the local pharmacy that you use doesn't have it, we can help you to source it and make sure that the script goes to a place where the drug is available. And we have, you can call us and we can support you with finding sourcing the drug, especially if it's unusual things like, I don't know, paracoxib or alfentanil, just some of the slightly more, the things that don't tend to be in stock. That would be great. Yeah, prescribing was a big issue and source of frustration. So can palliative care do their own prescribing? The answer is a mixture. So we have some specialist nurses who do prescribe and some who don't. They're all being trained, but that is a process that's going to take a few years for them all to become prescribers. Obviously, the doctors are able to prescribe, but at the moment we don't have FP10 pads. We're in the process of getting them, but for some reason, that is a long process for reasons that I don't understand. But so we will prescribe for patients, if we can prescribe, we'll prescribe for patients that we are seeing. So the specialist nurse, if they're seeing that patient, they will prescribe. But what they won't prescribe for is patients that are on our register but aren't being seen by a specialist. Because those patients, although they're on our list, they're not kind of known to that specialist nurse. So sometimes they will, either the doctors or the nurses will do that in an emergency if it's safe, but largely for those patients, they'll be asking you as GPs to prescribe. Similarly, if it's a specialist nurse that doesn't prescribe, they'll be asking a GP to prescribe. The other thing that came up was mask forms. So I know that this is a bit of a bugbear that they need re-signing every 8 weeks. If they don't get signed every 8 weeks, they are not valid, and it's we do get called in the middle of the night to redo mask forms sometimes for this reason. The decision that they need reviewing every 8 weeks was not made by us. It was made by a multidisciplinary regional group across BSOL and Sandwell. GPs were included in that forum, and it was felt that that was the safest way for these prescriptions to be held. Also, if someone's been discharged from hospital, that form should be reviewed within 2 weeks. So we can't change that. But what we can look at, and what we said was that we, in some circumstances, are probably asking for anticipatory medications too early. So really, we only really need them in the last kind of 6 to 8 weeks of life. The reason that we have tended to ask for them earlier is for fear of not having them when we need them, and then a crisis in the house, like out of hours, and not having the drugs for someone who's suddenly deteriorated. But we have made a change, and now we're not routinely asking for them. We're just asking for them in the last 6 to 8 weeks of life. But we will be reviewing if we kind of see an increase in incidents around not having the drugs in place. Because obviously, if we don't have them in too early, then there's less need for repeated mask signing. So the other thing that was said was that when we ask for anticipatory meds, sometimes if you're not familiar with what the ampule sizes are, that it can take you ages to kind of look that up, and worried that you might be putting the wrong one. So now when we ask for anticipatory meds, our standard email has the standard ampule size and strengths on the email. So hopefully that will make things a bit quicker for you. And the final thing was MDT meetings. So everybody who we met has said, please come to our MDT meetings, and we would really love to, but as every team is, we're pushed kind of with staffing and time, and there are 48 practices in Sandwell, and we have been out to some, and sometimes it can be helpful and sometimes it's really not. So sometimes we get there and there's no palliative patients discussed, and it's not a very good use of time. So what we're hoping to do, there is a change across Sandwell where wider complex MDTs are being arranged in a town-based arrangement. So there's 6 towns, and we hope that we will be involved in all of those 6 town MDTs, and that there'll be a palliative care focus. We don't know with what episodicity, is that the right word? We don't know how often yet, but so we're hoping that these wider MDTs will include us, and then that would be the place to bring complex palliative care patients for discussion. At the moment, it's under debate kind of how GPs will be involved in that. So not if GPs will be involved, they definitely will, but it's just how at the moment. It's not quite been finalised. So this is a bit of a watch this space, but what we're hoping is that these wider town MDTs will be a place for complex palliative care community patients to be discussed. But what we will say is that if you have a complex patient with palliative care needs, I wouldn't want you to be waiting for an MDT to get advice. So we're around, there's someone around every day you can call and get advice. So just call the hub, say you need to speak to somebody, and you'll either get, we'll get the appropriate person. It might be the CNS that knows the patient, might be a consultant. We'll triage it to what would help. So what does the future hold? We're continuing to try and meet with practices as much as we can. Obviously, there's this plan for town teams, which I've talked about, town team meetings. And we're looking at simplifying our referral form because we've realised it's a bit tricky. So once we start using that, please send us any feedback you have. Either it's great, it's much better, or actually this is still not helpful. And that would help us to tweak it. And that's it. I will hand over to Mike, unless there's any questions in the middle. Or do you want to wait till the end, Carolyn?
No, I think because it's quite separate topics. If there's any questions or comments, we'll give just a couple of minutes if anyone wants to say anything while Mike's just, because are you sharing on your own laptop, Mike? Yes, okay. So I'll stop sharing, and any questions, we'll just give like a minute's pause while he starts to share his slides.
Hi, I'm James from Cape Hill Medical Centre. We met with you, Carolyn. It was a little while ago now, but I can't remember whether we discussed it. You talked about kind of communication in the emails and follow-up calls for urgent things. Do you guys have any access to the GP systems like EMIS Web or System 1 for making entries? Because that obviously, if you can make entries, then that obviously means that we will get a lot of information about what's going on anyway, and could potentially streamline your email communications if we already know what's going on.
We document on System 1 in palliative care. So if we have a practice that's on System 1, that's much easier because they can read our entries. So then we might just say on the email, see System 1 for more detailed notes. We don't have access to EMIS though, so that's where we need to be giving a bit more information in our emails. Are you in EMIS at Cape Hill, are you?
Yeah, unfortunately we're EMIS.
Yeah, there's a mix. There's a mix. So it's more tricky, yeah.
Thanks. And the other thing I was going to say, that when we had the meeting with Carolyn, it flagged up that our palliative care forms were a few years out of date. Because I think we didn't realise that we had the option to refer patients who could just go onto your registers. We were only referring in patients who we were having trouble managing symptoms or there were concerns. So I think we've now got the new up-to-date form. So hopefully our referral numbers and our registers should match a bit better going forward.
Yeah, and the main benefit of that is that those patients have access to our kind of out of hours service and kind of direct access to us.
It was actually an outcome of that meeting that we're actually editing the form even more because it's a bit complicated. Sorry, Becky, I think no, it's okay. We're unmuted you because we're echoing. Yeah, so we're editing the form to make it much more simple. So it's very clear that you can just refer in even if there's no specialist needs. So that's to be coming probably be the new year now, but hopefully much simpler form. So that was the sort of outcome of that meeting as well. So that just indicates the usefulness of meeting practices and hearing things and making changes. I've shared the YouTube link just if anyone hasn't got it and wants it in the chat. So you can use that if you want to. But I think anyone that joins these, we do send an email out afterwards with links to things as well. Any more comments or questions? Otherwise, I will pass on to Mike, who will present his talk. Okay, thanks. Over to you, Mike.
Excellent. Well, good to be with everyone. And what I'm going to do now is slight change of gear. We're going to think a little bit about uncertainty when it comes to decision making at the end of life, but with a particular focus really on how that impacts us as people. So our kind of professional well-being. So that's where we're going to go for the next half an hour or so. And if anybody's got any comments or questions, just jump on in. So yeah, we're going to be looking at the reality of end-of-life decision making, the tension of uncertainty, and how that's just a normal part of medicine, is navigating uncertainty, and the challenge of both identifying and achieving patient preferences within that uncertainty, and then think a bit about the impact on us. So this was a quote from Claire Gerarda when she spoke to the Health and Social Care Committee about the state of the NHS a little while ago now, and she emphasised that actually the two most important solutions that we could do for looking after the well-being of the workforce in the NHS is to address the intensity of the workload, but also to allow for spaces in protected time where people can come together and talk about the emotional impact of their work. Obviously, Claire Gerarda has been the CMO for practitioner health for a long while, and so she's very well acquainted to the well-being of the doctor workforce within the NHS as a whole, and the number of referrals that come to that service. Before going further, I'm just going to tell you a little bit about myself for reasons that will become clear. Here is my life on screen, or at least a snapshot of it. So you've got a picture there of me and my wife Becca, as was a story of boy likes girl, girl not so sure about that, but after a little while gave me a try, and then pretty soon I put a ring on it. And now I'm a father of 3 daughters, so I'm totally outnumbered at home, and so I've got a photo of my daughters there. I'm also a lecturer in ethics at the University of Birmingham, so there's a blackboard on the screen there. I'm an assistant pastor of a local church in Harborne called Oasis Church, and so there's a picture of our church there, a painting of it. As you know, a physician in palliative medicine. I support Arsenal. I like football. Supporting Arsenal is chronically disappointing, but who knows, it might be our year. I like live music of all sorts of different types. So there's a picture of a gig there. The universe to me is fascinating, and so stargazing, you know, when I'm in a place where there's not too much light pollution, is a great pastime. I'm a Christian, so there's an empty cross at the center of my screen. This is my brother Joel, who's got Down syndrome and alpha-1 antitrypsin deficiency. I speak to him every night. He's hilarious and quite possibly the best person alive. And I like cake very much. I'm really delighted that my oldest daughter has gotten into baking a lot. That's my life on screen, or at least a snapshot of it. And the reason why I present this to you is because all of these different aspects of what make up my life, they dictate how I see the world, how I process the past, how I hope for the future, how I navigate the present. You've got a screen too. I wonder what would be on your screen. And so do our patients have a screen. And decision making at the end of life is all about how does the present situation impact upon the screen of this particular patient, and what's important to them, and what their preferences are, and what their values are. And that will lead to oftentimes there being different decisions about the same circumstance for different people, because the values and the preferences will change and be dictated to by whatever is on their screen. This is just an infographic that just demonstrates that it is predicted that the number of people who will be dying within the UK will increase by 40% up until 2040. And so we're seeing increased multimorbidity and complexity with people who are approaching the end of their life, and that's going to put a strain on our services. This is no surprise to any of us, but it does mean that we need to be very, very well engaged with understanding that there's going to be all sorts of tricky decision making that needs to happen as the years go by, increasingly so. I'm just going to talk to you about 2 different cases really to illustrate some of the difficulties when it comes to decision making at the end of life, and then I'll talk to you a little bit about some theory and practice for how we look after ourselves in the midst of that. So let me tell you about a 50-year-old lady called Sally who was looked after by our team. Obviously, that's not her real name. Sally lives with her husband and was had grown-up children. She loved music. There was a guitar in the room when I went to visit her at home. She also loved her garden and spending time outside in the garden. She was not a great fan of doctors. Nothing personal. She just doesn't really like going to hospital or going to the GP, she'd not therefore been to see her doctor. As a result, she presented very late with a breast lump and ended up being diagnosed with metastatic breast cancer at a very advanced stage. And even though she was a young lady, she was functionally really very disabled by the time of diagnosis. I was asked to go and see her because she presented with a 2-week history of nausea and vomiting, headache and constipation, and was becoming a bit more drowsy and was clinically quite dry. So when I went to see her at home, there was a few different differential diagnoses for what might be coming on, but leading amongst which, with that kind of confluence of symptoms, was could this lady have brain metastases, and could she have hypercalcemia? And there was a decision that needed to be made about what was the best thing to do about this. She was quite a young lady, and in order to be able to confidently make these diagnoses, an admission to hospital felt like the right thing to at least talk through and to offer. And so we did talk through that option. And actually, in this particular case, she decided she did want to go to hospital, where she had a CT scan that confirmed the presence of numerous brain metastases, and she had some blood tests that confirmed hypercalcemia that could be treated. but she really didn't want to die in hospital. So we needed to make sure it was a pretty targeted admission, and then she came back afterwards. And on this particular occasion, that all worked very well. She went into hospital for a few days, had those diagnoses. We did some advanced care planning so that we knew that thereafter we'd try and avoid hospital as much as possible and keep her at home and keep her comfortable on the SCP. She subsequently had another episode of hypercalcemia a few months later, and we decided at that point that, in conversation with her, that the best way to manage her was to treat that at home. And so via the epicenter team that we have here in the trust, we were able to ask people to go out to cannulate her, give her some fluids, and give her some bisphosphonate at home for the treatment of her hypercalcemia. Now, it's possible that she could have come into hospital and things could not have worked out very well. So it did feel like it was a decision that, although clinically was pretty clear what needed to happen, in terms of the interaction with her screen, it wasn't so clear cut. One of the things that can be helpful in these situations is to have a bit of an idea of, the kind of prognosis that is attached to certain different presentations. So we know that brain metastasis is common in the context of breast cancer, particularly breast cancer that is HER2 positive or triple negative breast cancer. And we also know that it is associated with pretty poor prognosis. So there is a scoring tool called the RPA prognostic tool, which helps to prognosticate for people with brain metastases. And really the key feature is what their Karnofsky is, or their performance status. So if a person has a Karnofsky score of less than 70%, which equates to a performance status of worse than 2, then actually they've got a poor prognosis, and their prognosis is likely to be measured in a short number of months in that case. It's helpful to know that, because of course that leads to justification to have an important conversation with that patient about what are their values, what are their preferences moving forward. Since time is likely to be precious, where do they want to spend that time? How does that interact with all the things that might appear on their screen? Similarly, with hypercalcemia of malignancy, again, we know it's a common complication of cancer, particularly with particular carcinomas such as squamous cell carcinoma of the lung, or breast cancer, myeloma. And again, the studies tell us that true hypercalcemia of malignancy, which is defined as having a raised calcium in the context of a low PTH, then the prognosis is poor. The median survival is 2 months after hypercalcemia of malignancy. And so certainly if you're having recurrent hypercalcemia of malignancy, the prognosis is poor. And just knowing these things can help to navigate some of that uncertainty about how to manage these conditions and whether a hospital admission would be in the best interest of the patient or not, in conversation with how it interacts with what's on their screen. So that's really in the context of cancer, where sometimes we feel a bit more familiar with the likely disease trajectory. But all of us would have seen this diagram before, which demonstrates the difference in disease trajectories for different disease groups. So the cancer line of actually a person remains with quite high function up until a tipping point where they decline quite quickly towards death. That probably isn't so relevant now because of the advent of immunotherapies and various other treatments, which means it can be a bit more tricky to know what's a complication of a treatment and what is someone who's approaching the end of their life. But we're quite familiar with the organ failure and the frailty lines, and how with these, you have patients who have a particular baseline and have an exacerbation of their underlying condition that leads them to the point of becoming very unwell, from which they may or may not recover. And being able to determine what is an exacerbation from which a patient might benefit from more intensive treatments and may recover, versus what is an exacerbation that is going to likely prove to be a terminal event, can be tricky and difficult to ascertain the difference between the two. And I think the first thing for us to do is to acknowledge that uncertainty, and to acknowledge that uncertainty quite openly with our patients and with their families. It's not always easy to say with any great certainty what a patient's prognosis is, and I think patients, in my experience, appreciate that honesty and candidness about it. as a throwaway, that does mean that we should be very nervous about any changes to the law that require us to know with certainty what a patient's prognosis might be for them to qualify for a particular intervention, but that's for another time. So let me tell you about Margaret. So Margaret is a 76-year-old lady with severe COPD, lived with her husband and with her dog, and had a devoted daughter nearby. She has got long-term oxygen therapy at home, and she chronically has saturations of about 86%, despite having 2 to 3 litres of oxygen per minute. She's got home nebulizers, and she'd recently utilised her rescue pack a couple of times in recent months, and was multimorbid and quite a frail lady. I was living downstairs with a hospital bed, and could really only just about get from the bed to the toilet, which was about 5 paces away, before she would become too breathless. She had frequent exacerbations of her breathlessness, with panic associated with that, and actually would, as a coping mechanism, quite often call into the palliative care hub to ask for subcutaneous medications of morphine and midazolam to help with this breathlessness and this panic. And on a number of different occasions, she'd had an exacerbation of her COPD to the point where it looked like this might be something from which she won't recover, and was started on a syringe driver to help to control some of her symptoms, only for her to then stabilize and get a bit better, and us to be able to take the syringe driver down. And this went on for several months. She did find it difficult to sleep at night, and actually the time when I was seeing her was during the heat wave a couple of years ago in the summer, and she found extremes of temperature very difficult actually to experience. So she was frightened and heavily reliant on her family, who were beginning to find it all a bit tricky looking after her. But she did not want to go to hospital or to die in hospital. I was asked to see her a couple of times because of exacerbations in her breathlessness and panic, and so was quite heavily involved. What we did for her is take a holistic approach to how we look after her, and so from a physical point of view, we did optimize her oral opioids to help to manage her breathlessness, and we know that evidence suggests that for kind of chronic breathlessness, using opioids, the equivalent of morphine, 30 milligrams over 24 hours, can be helpful. A dose higher than that tends to cause more problems than it solves at that point. So we optimize her opioid regime for her breathlessness, but also really emphasize non-pharmacological techniques for her breathing. Fan therapy, rectangular breathing, and involve the respiratory nurses in helping with some of these breathing and anxiety calming techniques. We explored with her the kind of hot cross bun theory in terms of the association between breathlessness and panic, and discussed some thought therapies to help to de-escalate the anxiety that she was feeling. She'd often feel like she didn't have enough oxygen, she couldn't breathe, and that she wasn't going to be able to see it through the night, even though this had been going on for many months and she'd always had seen it through the night. And so we talked through that dynamic and reassured her, explaining that calling the hub was always an option that's available to her, and if someone comes out and deems that she does need subcutaneous medications, we can deliver those, but that it might be best to focus on some other ways of controlling her breathlessness and panic. We also liaised with her daughter and her husband about that to give them the support that they needed, because they felt that they were at wit's end, and we explored her screen again and what gives life meaning and what her preferences were. It's really clear that at no point would she want to go to hospital. The SPICT tool can help with prognostication in situations like this, and I know that's been covered in previous talks. I'm not going to go into any detail, but that can be a helpful thing to use. The headline with this lady is that I went to see her and we talked through those non-pharmacological techniques and how she'd been through the night every time up to now. So there's no reason why she won't make it through the night again, and to employ some of those non-pharmacological techniques for calming herself down and controlling her breathing. And then I found out 5 days later, having written a letter that really encapsulated all of this for her, that she died and that she'd had an exacerbation from which she hadn't recovered. And our team did go out and they did administer some medications to her. to help with her breathlessness and her panic. But certainly it was a surprise to me that she'd died so soon after having seen her. Not because that was not within the realm of possibility, it absolutely was clear from her history, but because I hadn't anticipated that the next exacerbation would be a terminal exacerbation for her. And that really is where I wanted to get to in terms of the impact on ourselves of navigating the messiness of medicine. And I want to talk to you a little bit about this concept of moral residue, which I came across from John Ives, who is an ethicist who was at the University of Birmingham, who's now moved to Bristol. Uncertainty is, as we've already said, just a normal part of medicine. That actually it's every day we'll be navigating the clinical scenario before us and understanding that actually it could mean one of several things. There are more than one ways to manage things, and we're kind of navigating that uncertainty with our patients all the time. And it doesn't paralyze us, we just work our way through that. But uncertainty is one phenomenon. Making a wrong decision is something different when we think, oh, in retrospect, I've chosen something which I shouldn't have done. But then there's another phenomenon that John Ives talks about, which is moral residue, which is the remaining feeling of having done something wrong, despite having made a decision that one assents to be right. So having found out that this the lady with COPD died, it felt to me a bit wrong. It felt like, oh, maybe I did something that I shouldn't have done in that particular consultation. Maybe I should have taken a slightly different approach. Whereas actually the reality is, knowing what I knew then, and based on the information that was available to me at that time, the advice that I'd given was the right advice to give. It just didn't sit comfortably that so soon after that she'd died. And John Ives points out that actually moral residue, in a sense, it's a necessary feature of a moral dilemma, where sometimes it feels like there's no entirely satisfactory option, but failure to make any choice in a particular clinical scenario would be the worst thing of all. We can't just pretend that it's not happening. We have to make decisions, even though very oftentimes decision making isn't easy. It feels like you're sometimes choosing the best, worst option available. And this is a phenomenon that I think is very common. I think that clinicians, the longer that you work in medicine, the more that you will be exposed to this kind of phenomenon of moral residue, of carrying with us some of the consequences of difficult decision making where we've not made a mistake. It's just that things haven't worked out necessarily the way we'd have liked them to, and we've had to make some tough choices along the way, and we carry that. And John Ives suggests that some of the reasons that contribute to this feeling of moral residue is medical education, where it's often suggested that challenging ethical situations can be articulated and resolved quite simply and concisely, and that there's always a correct and satisfactory solution. Whereas actually we should probably be preparing our trainees for messiness and uncertainty and the kind of moral residue that can come with that, and to disassociate this from failure. It's actually part of the human condition, and being exposed to the human condition at its extremity, rather than that things have necessarily gone wrong because it's not all neat and tidy. It's also exacerbated by increasing medical complexity, and the slide earlier demonstrates that that's only likely to increase. And moral residue can come when you've got the convergence of cultures, when you've got a patient's screen interacting with a physician's screen, and sometimes that can make it all feel quite awkward, because patients might make choices that we don't understand because they don't neatly align with our personal values and the way that we see the world, though they do make decisions which are consistent with how they see the world and the things that are important to them. And so all of this adds into this phenomenon of kind of moral residue. And if it's goes unchecked and unacknowledged, then it can lead to some adverse outcomes. There's just exhaustion and burnout. It can adversely affect decision making. We can find ourselves becoming a bit more risk averse, and it can negatively impact both teams and personal well-being. So how can we begin to approach it? I think a lot of it is to do with the professional culture that we have and the culture that we foster within our teams. Certainly the evidence nationally is that resilience is more of a function of teams than it is of individuals, and so the teams that we work in are really important. And Professor Brené Brown has done some study into well-being as a whole. She's a sociologist in the States who's written lots of popular works, but also some academic work. And she has studied for over 10 years the characteristics of people who live with well-being, or she describes it wholeheartedness. And there are 3 that she's identified. The first is courage, and by courage she doesn't mean rescuing a cat from a burning building with great bravery. She points out that courage comes from the Latin cor, which means heart. And so she said ordinary courage is being able to speak from the heart, which means to say being able to be imperfect and take off the mask that we often wear, and actually be able to say it as it is in a safe space, in a place of psychological safety. There's still a lot of stigmatization around work-related stress, but actually it's something that all of us encounter at one point or another. And so having the ability to be courageous enough to say, this is what's going on within me, and this is how my work is affecting my screen right now. Because when we have safe spaces to do that, that can lead to compassion, both towards self and towards others, because we realize that actually the person before us is just like me, and that can lead to not just compassion but connection, a sense of not being on our own. And we're neurobiologically wired for connection. We need it, and it's built on this authenticity. And so the kind of common feature to all of this is embracing our ordinary humanity in the context of working in healthcare and navigating difficult decisions at the end of life. And actually, there's a study that was done a couple of years ago now, which demonstrated how this can work effectively in the context of general practice. It's a qualitative study, a multi-center study that had in-depth interviews with 47 GPs, and they sampled 3 types of GPs: GPs who had experience of mental distress in the past, or were currently experiencing mental distress, or who had no such experience of that. And what they found, that there were certain themes that contributed to distress. They were emotion work, so the idea of engaging with those patients or those tasks which are particularly associated with a lot of emotional labor, which will be a lot of what we're doing. Practice culture, so the sense in which your practice felt like a safe place to be, a place of psychological safety, so a supportive place. And then work role demands, so fears of mistakes and complaints. And what they found was that the willingness of colleagues to talk about vulnerability and illness was protective. This does tie into a study that was done by Google called the Aristotle Project, where they were looking at all of their different teams across the world and how some of them were functioning really efficiently and others not so much. And when they dug into why that was, the feature of the teams that were most efficient and most productive were teams that had psychological safety, where they felt a sense of belonging and a sense of being able to be who they really are and to speak from the heart, to be courageous. So providing a safe space for this was suggested as being imperative in this particular study, and they suggested we need to tackle the culture of invulnerability early on in medical training, so that feelings and anxieties are normalized, understood and validated. So that's really all that I wanted to say. To leave that with you, certainly what that's looked like for us in our trust is that we've created some very specific environments for people to be able to get together and talk about the good, the bad and the ugly of being in healthcare, and that has been shown to be very helpful for us locally. I wonder what it might look like for you in your particular trusts as you navigate uncertainty in decision making at the end of life. Thanks so much for listening.
Thank you, Mike. Has anyone got any questions or queries about that? Or comments even? Becky's got her hand up. I'll mute myself and you can speak.
I only wanted to say that, why is Otto not on your screen?
Otto, for those who don't know, is our new puppy who arrived about 5 weeks ago, and should be not just on the screen, but the only thing on the screen, because it's dominating everything right now. So I need to update that slide.
James, have you appeared on video to say something, or just to?
Oh well, no, I was just going to say that was really really interesting, really good talk. Thank you for sharing cases and the other stuff about uncertainty. It is really difficult. I feel we often get quite hung up on this idea of reversibility and whether something is treatable or not, and I feel like sometimes that does kind of miss the point sometimes of focusing on kind of what's important to people, and it doesn't always necessarily matter whether it's treatable or reversible. If they don't want to go to hospital, don't want to have a certain treatment, then there's but I feel it's really difficult. Often that's something that we end up kind of putting on respect forms, things like that, but I often feel it's not hugely helpful.
It's really unhelpful, I think. I think that line of, would go into hospital for anything that's reversible, because very often the pre-terminal event nearly is always something that is technically reversible. Technically, you could try and do something about it. But that doesn't mean that the attempt won't lead to that person dying away from their loved ones in a clinical environment where they're going to be prodded and poked. So much better to be thinking of actually this whole process of ACP is identifying what's important to this person and how that fits into treatment decisions, rather than dealing it down to just the discrete decisions that we need to make about whether they have an infection or not. I mean, of course that's important, but it's within that bigger kind of perspective. But yeah, I agree with you. Otherwise you're left feeling like I'm having to make a crisis decision, and I'm catching up on those things when it could have happened earlier.
Great, thank you everyone for coming. Well, I will stop the recording now. Obviously we'll send an email out with some information afterwards, and do communicate with us. However, call in if you've got any more questions. This will be shared on YouTube because I know lots of people watch it, or some people watch it on catch up afterwards. But thank you all.
Thank you.
Thanks.
Thank you.
Bye, Alice.
Oh, I can't stop the recording. How do I stop the recording? Here we are.